Hello and thank you for listening to the second season of the ISTAART PIA Relay Podcast series, brought to you by Dementia Researcher. ISTAART is a professional society and part of the Alzheimer's Association, representing scientists, physicians, and other dementia professionals active in researching and understanding the causes and treatments of Alzheimer's disease and other dementias. In this 5-part series, we have once again asked members of the ISTAART professional interest areas to take turns at interviewing their colleagues and being interviewed themselves, with the interviewee going on to be the next episode's interviewer. We'll be releasing one of these podcasts each day in the build-up to the Alzheimer's Association's International Virtual Conference to showcase the work of ISTAART PIAs. Thank you for listening.
Hello everyone, and thanks for joining us. I'm Joe Kane, and I'm a clinical academic lecturer in old age psychiatry. I work at Queen's University Belfast, and I'm communications officer for the Lewy Body Dementias PIA. Today, I'm delighted to be talking with Zahinoor Ismail. Hello Zahinoor, can I start by asking you to introduce yourself and tell us which PIA you're involved with, please?
Hi, I'm Zahinoor Ismail, and I'm a professor of psychiatry, neurology, epidemiology, and pathology at the University of Calgary, affiliated with both the Hotchkiss Brain Institute and the University of and the O'Brien Institute of Public Health. And I'm also affiliated with the University of Exeter and their old age psychiatry program. I am the academic lead of the Neuropsychiatric Syndromes professional interest area.
Perhaps to start with, you could tell us a little bit about your own research. What brought you to dementia research, for example?
As a child, I was close to my grandmother. And, from what I've read is that if you have strong, relationships with seniors when you're young, it seems to be more of those folks, say in the medical field, go on to work in geriatrics. And I think I'm fairly textbook that way. I toyed with, different fields in medical school, but the brain I always thought was the most fascinating organ. And so I ended up pursuing old age psychiatry, geriatric psychiatry, with then additional subspecialty training in behavioral neurology and neuropsychiatry. So my work really captures the interface of psychiatry and neurology, especially with respect to psychiatric symptomatology, observed through a neurological window or framework. Some of what I do is using neuropsychiatric symptoms as early non-cognitive markers of dementia or as prognostic markers of dementia. And a great deal of this comes out of the PIA. The large bulk of my work in my lab involves mild behavioral impairment. And the MBI work really evolved from the Neuropsychiatric Syndromes PIA, and it's work that continues on in the PIA, but it certainly greatly influenced and informed my career. MBI is characterized by the emergence in later life, so de novo emergence of neuropsychiatric symptoms that are persistent. So they're not transient or fluctuating. They persist for a number of months, at least 6 months. And attendant with the emergence and persistence of those symptoms in older life is a greater risk of incident cognitive decline and dementia. For some, it's the index manifestation of dementia. And this is pretty novel because we have a cognocentric paradigm of dementia. We appreciate cognitive changes. If someone comes into clinic and they complain of memory impairment and they've always had memory impairment, then you say, okay, well, that's not dementia. We're looking for change. But for some reason, that same notion of changes in behavior doesn't seem to resonate or penetrate. If someone comes into clinic and they're 67 years old and they've never had, a psychiatric history, we should give them credit for those 67 years. And if they present with new onset psychiatric symptoms, something's up. And if we look back at the history of dementia, Auguste D., Alzheimer's patient that we all know and have read about, presented to hospital not with cognitive symptoms, but with emotional dysregulation and suspiciousness. So when we look at the epidemiological data in dementia in general, 59% of people present with a neuropsychiatric symptom before a cognitive diagnosis. And we kind of expect that for FTD, with disinhibition and apathy baked right into the construct of FTD. And we expect that with Lewy body, with psychosis being such a prominent part, but it's not really thought of in Alzheimer's. And again, when you look at the data, 30% of people who develop AD actually have an initial behavioral prodrome. So if we are looking for earlier markers of the most common type of dementia, then perhaps invoking and including neuropsychiatric symptoms is one way that we can do that. So that's the work of my lab, and to a degree of our PIA as well. And there are many different projects going on, whether it be looking at the cross-sectional brain behavior correlates, associations with imaging or fluid biomarkers with cognitive status, and then changes in all of those markers over time. I also do clinical trial work, not only in terms of the overall dementia cognitive, interventions with novel agents, but also in terms of neuropsychiatric symptoms, and have 3 ongoing studies right now for agitation and dementia. So it's an area in the dementia field. It's the neuropsychiatric symptom, which I seem to be spending more time with at an intervention level. And I'm very interested in teasing out the different domains within the IPA diagnostic criteria for agitation. I feel that the excessive motor activity, the verbal aggression and the physical aggression, while related, probably captured different groups at different stages of illness. And we've done some work in this area now. We've just published a paper in Alzheimer's and Dementia that utilized both the Cohen-Mansfield Agitation Inventory and the Neuropsychiatric Inventory clinician version to derive and abstract measures that capture the 3 IPA agitation domains, and then we validated them and are exploring that in other data sets, including a Canadian study called STAN, and looking to see if that clinical impression that verbal aggression precedes physical aggression, if that's the case, is an earlier way to detect agitation, and then can intervention more rely more on non-pharmacological interventions or more benign or less impactful treatments. What we don't want to see is when agitation is defined, is described or initially captured at a crisis stage, when someone punches someone else or pulls a staff's hair or gouges their eyes. Then you're in a situation where it's emergent. They might get sent to hospital. They might lose their placement. Antipsychotics may be necessary. We don't want to do that. So what I really am interested in is capturing the agitation syndrome earlier on in the disease course when it's less acute, and then cholinesterase inhibitors or serotonergic drugs, in addition to non-pharmacological agents, might be more appropriate in order to decrease the burden of antipsychotics. And again, I think cholinesterase inhibitors are another area in which I'm interested in, because we are in the stage where not only are we de-prescribing them more often than prescribing them, that there's a clinician nihilism such that they don't even want to start these medications. And what I see in my nursing home practice, for example, is that when cholinesterase inhibitors are discontinued, I see emergent agitation psychosis usually about 6 or 8 weeks. And the longer term data, as they start to trickle out, are showing, hey, wait, these medications may actually treat neuropsychiatric symptoms, even though that wasn't evident in any of the short trials. A really nice paper out of the Swedish Dementia Registry showed that those patients with AD who are prescribed cholinesterase inhibitors have a lower probability of being prescribed antipsychotics. To me, that's really exciting. So if we're trying to find interventions that are safer, we have medicines already that might be helpful. So that's something I'm interested in as well in terms of finding optimal pharmacotherapy.
You mentioned your work in nursing homes, and of course, during COVID, we know that it's been quite difficult to use some of the non-pharmacological methods that we favour when it comes to behavioural disturbances, and also we know that the environment can be a big factor contributing to MBI and behavioural issues in general. How has COVID influenced your day-to-day work, your clinical work?
Joe, this is a remarkable thing. We had this global pandemic, and it fundamentally changed the nature of our interaction with our patients and their interaction with the world, and it was all for the worse. Over the last 15 months, I've been in practice 22 years now, and over the last 15 months, I saw more psychosis in that patient population than I ever had before. And strangely enough, Joe, I saw more Parkinsonism as well. And that was really odd. And I'll say in the series of homes I'm working in now, I have about a 5-year reference range. In this last year, they've been more agitated, more psychotic, more Parkinsonized. We've always written in grants and studies that non-pharmacological interventions are safe. And I actually wrote in a recent protocol that, well, maybe not as safe as we once thought, given the infection risk. And it's challenging. How do you administer Montessori interventions remotely when the nature and the benefit of that comes from the tactile work, from the sensation and the patients using their hands to express, say, lost, verbal skills. Like, it's extraordinarily challenging. But my goodness, I found them to be, sicker than I've ever seen them. Social isolation certainly being a part of that, because with the easing of restrictions, for a number of people, we've seen the agitation decrease a little bit. But you wonder also about the neuro COVID and the CNS sequelae, of direct, central consequences of the virus, but more recently studies showing that there's a CNS inflammatory burden. What is this going to do down the road? Are we going to see a dementia pandemic secondary to the COVID pandemic? What is the nature of our relationships with our patients gonna look like?
Yeah, it's a big challenge ahead, certainly, for anyone working in clinical services. Could I ask you specifically about the work that you're doing in prodromal DLB and in PDMCI regarding behavioral disturbances and neuropsychiatric symptoms?
Certainly. In the same way that we've applied MBI to Alzheimer's, because neuropsychiatric symptoms in preclinical and prodromal AD were underappreciated, we can apply that to other dementias as well. It can be applied to FTD because we know there are robust, cohort of symptoms that can emerge beyond just apathy and disinhibition. In DLB, it's really quite robust, especially in psychosis, but also mood, anxiety, impulse discontrol, etc. With the complicating factor that if they are on, dopaminergic agonists, there might be some impulse discontrol there. We looked at PDMCI, a group through a cohort run by Dr. Uri Monshi here in Calgary, and administered the MBI checklist to this cohort of patients with Parkinson's, and found that those with higher MBI checklist scores had lower MoCA scores, Montreal Cognitive Assessment, and were more likely to be diagnosed with PDMCI as opposed to PD. We also found some middle temporal atrophy in that same group. Subsequent analyses then showed some functional connectivity differences as well. So the story in the alpha-synucleinopathies seems to be thus far similar, such that the neuropsychiatric symptoms measured within the MBI framework, because the MBI framework is more specific in that with the emergence and 6 months persistence of symptoms, some of the transient reactive types of symptoms that might have been captured if you're measuring neuropsychiatric symptoms traditionally would be excluded. So you get a stronger signal for what are possibly behavioral sequelae of underlying functional disconnectivity and neurodegeneration. This applies in the synucleinopathies such that it seems that in those who have PD, the MBI burden is associated, cross-sectionally with biomarkers and cognitive clinical symptoms that are consistent with, say, the posterior deficits that are associated with a greater risk for incident cognitive decline and progression to DLB. So there is ongoing work into that area, but I think there are certainly parallels with AD in the synucleinopathies.
And do you think that there is scope within the MBI checklist that your PIA has worked on for adaptation for Lewy body disorders or a different threshold, for example?
Certainly, I think the only question is actually the threshold. The MBI checks, again, and this is I think one of the remarkable things that came out of our PIA, is turning out to be really a robust rating scale, and every analysis seems to really show that it's capturing things that are very interesting and helpful. It's divided into 5 domains consistent with the 5 MBI domains. So the first is apathy, and there are even specific symptoms for each of the apathy subdomains of decreased interest, decreased initiative, and decreased emotional reactivity. So you can really kind of get granular that way. And one would want to probably look at different brain behavior correlates of even of the apathy subdomains, because I think they are relevant. The second domain is emotional dysregulation, and that includes both mood and anxiety symptoms. And based on our work so far, those really seem to be amyloidopathy type symptoms, right? How that plays out in the synucleinopathies is unclear, and knowing that there's overlap between these proteinopathies and different clinical dementia syndromes. The third domain is impulse dyscontrol, and it's the broadest domain. Recently, really nicely analyzed by Toni Saari from Finland in a network meta-analysis that's out in International Psychogeriatrics, showing that there are some core symptoms. Argumentativeness, for example, is one that's really important at detecting the overall clinical syndrome, but also connecting to different, types of impulse dyscontrol symptoms, and those can be kind of divided into 2 parts. One is that sort of agitation, aggression, irritability, impulsivity that we can see again often in Alzheimer's. But then there is the reward, salience, and response kind of disinhibition component, and part of that, those sort of orbital frontal cortex type behaviors that we see, and that subdomain within the impulse dyscontrol domain, I think is probably quite relevant to non-AD dementias. The fourth MBI domain is the social cognition domain, looking at tact and empathy and sympathy and social behavior and intruding on other people's activities or speaking to people as if they're familiar. That probably is mostly FTD type of behavior, but it hasn't really been measured in a systematic way to see to what extent it really applies in other dementias as well. And then the fifth domain is psychosis, which includes not only hallucinations, but delusions as well, which we know is certainly relevant to the Lewy body dementias and synucleinopathies. So to me, and we're including the MBI checklist in our observational cohorts of, Parkinson's and PDMCI DLB. I think there's definitely relevance for not only capturing symptoms, but then using those domains to look at kind of endophenotypes or different aspects of the synucleinopathy, which might be associated with different clinical cognitive biomarker or, longitudinal outcomes.
What are the hot topics in your field at the moment?
I think biomarkers is hot everywhere, and it's certainly hot in neuropsychiatric symptoms, whether it be any type of neuropsychiatric symptom measured anyway, or whether it be mild behavioral impairment as a global construct or domain-specific analyses. Understanding, the availability, the utility of biomarkers in their relation to these symptoms is really important. And one can look at it both, but one can look at it two ways. You can frame the measurement of these MBI symptoms or neuropsychiatric symptoms, which are very easy to assess, with usually a very quick informant rated measure, then that captures a group that may be enriched for biomarker positivity. Alternatively, the biomarkers, if you look at, say, tau PET imaging and where is the tau, or if you look at, MR in terms of atrophy, to what extent is that associated with neuropsychiatric symptoms, with MBI domains or global MBI burden? And that kind of bidirectional approach is being investigated in a lot of different labs, certainly ours. The most practical is can we get easy to access biomarkers that associate with dementia risk? So, for example, in the NIAAA research framework for Alzheimer's, with the amyloid, tau, and neurodegeneration, in prodromal disease, when there are objectively measured cognitive symptoms and AD biomarkers, for example, we kind of know a little bit more the role of the neuropsychiatric symptoms, in that when you take two groups of people with MCI, those with neuropsychiatric symptoms and certainly with MBI are more likely to progress. In the normal cognition group, it's a lot harder, and it's a lot harder to aim your PET scan or your lumbar puncture needle, at people who are objectively normal in cognition. I mean, and I do lumbar punctures, and my research ethics board allows me to draw CSF from cognitively normal participants, especially if there's risk. But I have other collaborators in various parts of Europe, and their ethics board won't allow it. So finding a blood-based biomarker is obviously a huge, research endeavor around the world, because it allows us to find those preclinical folks. Consistent with your field as well is, can we find a marker that's easily accessible, that's not part of the ATN traditional framework? Amyloid, p-tau, tau, neurofilament light seems to be a marker, probably more useful prospectively than cross-sectionally. But can we find, synucleinopathies? Can we find, markers for different dementias, and ones that associate with neuropsychiatric symptoms in advance of cognitive impairment, that would allow us to also help differentiate from general psychiatric phenomenology in older adults? We know there's a great degree of specificity conferred from the stipulations in MBI that symptom emergence de novo and symptom persistence confer in detecting risk, but are there biomarker correlates that even amplify that signal, such that then now you have a real consideration as to whether or not you would engage more detailed measures, both clinical, cognitive, and imaging. But that's when the primary prevention story starts to come in, or even secondary prevention in advance of cognitive symptoms. Is this someone in whom you would administer a disease-modifying drug? And I think those are areas in which we're really, the field is exploring, and then finding better ways to treat these symptoms in those who are suffering from dementia. While the field has moved extensively to capturing preclinical and prodromal disease, we don't want to forget those who are the majority who are actually, experiencing dementia and suffering from the various neuropsychiatric symptoms. How can we identify those symptoms, treat them better, find medications and non-pharmacological interventions that are associated with efficacy and safety, COVID included, and ensure that we have optimal quality of life, that we ensure safety, that we can preserve agency and personhood in people with dementia. When in the context of neuropsychiatric symptoms, agency and personhood can be lost or overlooked or ignored. So really embracing that internal world of someone with dementia to determine, to what extent are these symptoms affecting their quality, and how can we improve them, and how can we engage everyone else to appreciate the importance of these symptoms, because maybe they're not as concrete as cognitive symptoms, but they are important. They are core criteria. They're fundamental to the disease course. And so increasing the profile and the awareness of those. And I think that's where syndromic criteria are very important. So I mentioned the IPA agitation criteria, which I think are landmark and really very important in our understanding of agitation. The IPA updated the psychosis criteria in neurocognitive disorders, and we included mild neurocognitive disorders, MCI, in that group. In harmony with that, our PIA also developed research and biomarker criteria for psychosis in Alzheimer's and related neurocognitive disorders. And these new psychosis criteria allow sort of, biomarker research in advance of overt cognitive impairment for associations with psychosis in late life and dementia. New apathy criteria have just been published. They're either in press or they're finally published, which take the Philip Robert's pan-diagnostic apathy criteria and focus them in on neurodegenerative disease and neurocognitive disorders, and with the 3 domains that are reflected in the MBI checklist and the MBI criteria of decreased interest, decreased initiative, and emotional reactivity. Where we don't have good syndromal criteria yet are for social cognition changes and for mood and anxiety disorders. And that, mood and anxiety disorders, and mood and anxiety symptoms being probably the most common in dementia. And yet we are still maybe perhaps stuck on a DSM framework for that, or an ICD framework, and it doesn't reflect the underlying neurobiology. So notwithstanding the fact that every robust treatment trial of antidepressants in dementia has failed, we still recommend treatment of depression. And so why is that? and I think our criteria, which are based in psychiatric constructs in early and midlife, a neurodevelopmental model of psychiatric symptoms, is different from the presentation of anxiety and depression, those types of symptoms in neurodegenerative disease. If you think about it, DSM stipulates that that the symptoms cannot be better accounted for by another medical issue. Would neurodegeneration, and the buildup of amyloid, tau, synuclein, vascular burden not be considered a medical condition that would better account for these symptoms? And if so, why are we still using DSM diagnostic criteria? This is the dilemma, and our field needs to really embrace nosology better, and distinguish between chronic and recurrent psychiatric syndromes and neuropsychiatric symptoms as sequelae of brain diseases, which also leads then to measurement-based care, which is another area of great interest for me, and understanding what is the best source of information. I mentioned agency and personhood. We want to inquire and try to understand the internal world of someone with dementia. But when they have anosognosia, and that anosognosia can not only be for cognitive deficits, but for functional deficits and for neuropsychiatric symptoms, this really changes care. If someone has anosognosia for neuropsychiatric symptoms and they come into clinic, how's your mood? Oh, I'm pretty good. Does that necessarily tell you how they're doing? And so we need to be aware of that and proactive, such that any assessments of cognition, function, and behavior should be assessed incorporating both the patient and a informed caregiver, reliable informant. And this actually is in our most recent iteration of Canadian dementia guidelines, explicitly that self-informant reports of cognition, behavior, and function are required for thorough dementia assessments and workup. And I think our field really needs to appreciate that there can be that affective, or behavioral anosognosia, because if someone says they're fine, we don't know that they are, and they can say their cognition is fine, and we administer, an MMSE or a RUDAS or a MOCA or an Addenbrooks or SLUMS or whatever we want to, and we would see that objective difference. But if they say they're not depressed or they're not anxious, where's the objective, frame of reference? And without that, our clinical work is impaired. So I think we need to explore that more, and that's again work I think that is important in the field and ongoing.
I think that's really fascinating. I think the idea that we view several neuropsychiatric syndromes through the lens of neurodevelopmental and working age psychiatry, and the idea that we should be embracing a whole different paradigm is really challenging, and really it makes a lot of sense, and it's a bit frightening as well as a practitioner.
It is. Again, it comes down to nosology. If you look at DSM criteria, its frame of reference is 2 weeks. Have you had these symptoms over 2 weeks? Sure. But what about the natural history? And to me, the real goods come in the development of these symptoms. Depressive symptoms in an adolescent versus someone who's 35 years old versus someone who's 45 versus someone who develops them at the age of 70. That is as a clinician, as an epidemiologist, those are distinctions that are really, really important. Why do our criteria and our rating scales, why are they silent? You look at a Beck anxiety inventory, a Beck depression inventory, they measure cross-sectional symptoms over a 2-week range. The geriatric depression scale over a 1-week range. I mean, in older adults, where is the understanding of the evolution of symptoms? And this is a discussion I have with my trainees in the emergency room, sometimes at 3 a.m., because someone will come into the emergency room and be 57 years old and have a first episode psychosis and will be presented to me with a diagnosis of schizophrenia. And I say, okay, is there a past history of this? Is this the first episode? What is the hormonal status? Are they perimenopausal? And our clinician trainees are not taught to think of natural history. And so they just take, cross-sectional assessments consistent with our larger nosological frameworks of DSM and ICD, and not really inquire about the natural history and the evolution. So to me, that's an area in our field that really requires great work.
Could you tell me a little bit about the committee and how your group is organized in the PIA?
Neuropsychiatric Syndromes Committee is co-led by someone from academia and someone from industry. And that's been a partnership, I think, going back, around 10 years or so, and was developed to foster, a partnership and inform drug development and testing, to include, industry in the conversation, as opposed to having a siloed understanding. And so we continue that. And I think it's very, very helpful, because we have insights into clinical trial design and regulatory issues that we might not, as a clinician, as a researcher. And at the same time, those involved in developing and testing, pharmacological interventions have an idea how clinicians and researchers think, out in the field, which can inform study design. And so the combination of the two is really a nice, petri dish and idea generator. It works really well. We have 10 members of the executive committee, which is diverse, and we look at imaging and biomarkers and neurostimulation, but also measurement. We also look at person-centered issues like ethics, sex and gender and diversity. And, we have members in training and, like yourself, communication members, and members across the spectrum of experience, of fields, of expertise. So, clinical fields, while heavily influenced by psychiatry and old age psychiatry, we have neuropharmacology, neurology, vascular expertise. We also have, a mixture of clinician researchers and the researchers involved, clinical trialists and epidemiologists, imaging experts, measurement-based care, phenomenology, et cetera. The group is robust and interactive and very, very friendly and fun. I mean, I really enjoy the time with our PIA, and the discussions are interactive and robust and thought-provoking, and everyone's just really, really nice. So it's a fun group.
Speaking of your group, and you mentioned early career researchers, how can they get involved in this fun group?
I think so. We welcome early career researchers and have roles for them, and we have a dedicated person to liaise with them and support them and address trainee needs. One of our goals, actually, in this next year is to develop a more formal mentorship program for junior members, knowing that trainees or early career folks have mentorship in their own institution. Depending on the size of that institution or the busyness of their mentors, we're hoping to provide some sort of kind of lateral mentorship as well for someone from a different institution with a different perspective, still appreciating and respecting that existing mentorship that someone may have. So over the next year, we're going to flesh this out more, but embracing junior members is really important to our PI. And I'll speak to my own experience in that my research career is extensively built on work that came out of the PIA, 10 years ago. And I really want to make sure that other people have that incredible opportunity. I come from an institution, especially, 10 years ago, where there wasn't that degree of expertise in neuropsychiatric symptoms and that neuropsychiatric dementia interface. And having the exposure to thoughts and support and ideas from the PIA at that time was seminal in my career. And I really want to make sure that our PIA continues that, because this is how our field grows. And so embracing junior members is our strength, and our senior members are generous, are intellectually generous to support and help junior members with research ideas, with constructs, with implementation.
What does your PIA have planned, and what are its aims for the coming year? Will you be presenting at the AAIC?
We will be. So we do have an FRS, and we submitted 2, and 1 was accepted, and involves clinical and cognitive outcomes and biomarkers of neuropsychiatric symptoms, sex differences in ApoE and neuropsychiatric symptoms. We have MBI included in there. Devanand is presenting the results from his lithium AD, the LIT-AD study. Very exciting. And we also have just, many posters and a few oral presentations as well. Our past chair, Corinne Fisher, is actually presenting the research biomarker psychosis criteria. And I think that'll be really interesting, exciting, because as I mentioned, they are in harmony with the IPA criteria and intended to really foster research in, systematic research into biomarkers in earlier stages. We have posters across, all the topics that I've discussed today. My own lab, I think, has about 10 posters in presentations. It's to me, that's one of the best parts of AAIC is the ability to see what people are doing at a very current level. The fact that there's so much in neuropsychiatric syndromes and neuropsychiatric symptoms to learn, and it's robust and it's moving fast, and you've got all the experts there. So I think it's a fantastic learning opportunity. We're doing some networking as well with junior members, and then down the road we're going to have some more workshops on various neuropsychiatric symptoms and across the cognitive spectrum, from normal cognition through to subjective cognitive decline to MCI through to dementia proper. So we're trying to capture the spectrum.
That sounds great. You've definitely sold me on a few of those sessions. Certainly the lithium and AD sounds absolutely unmissable, as do a few of the workshops as well. So
that's going to be really cool. As a sneak peek, the abstract is out, but there's a psychosis effect with lithium, and I was very excited when I saw that abstract. Again, which is in press in the American Journal of Geriatric Psychiatry, but Dev is going to go into detail, and so there's an agitation effect, a psychosis effect, a global effect. Very exciting data, and I think warrants a larger study.
Thank you very much. It's actually time to end today's podcast recording. Before we go, can I have one final question? What advice would you give to any aspiring dementia researchers out there who are thinking of looking into dementia?
My advice would be to not only look at current constructs and paradigms, but also to try turning them on their side and exploring different angles. Like we discussed, psychiatric symptoms don't have to be viewed in a neurodevelopmental framework. They can be viewed through a neurodegenerative one. So, bouncing around ideas, and with yourself, in the shower, with other colleagues and friends, with senior clinicians and scientists in PIAs, looking across fields. The PIA collaborations are a great way to take ideas from one field and cross-pollinate into another. Because, and this certainly happens clinically, but it happens in research as well. And sometimes we get into kind of a fixed mindset. And if we have that kind of growth mindset of exploration and being creative, and I think, just not being afraid to ask wacky questions is to me advice that I would suggest. And I can go back. I'll finish it off with Douglas Adams and Hitchhiker's Guide to the Galaxy. And when the Heart of Darkness is created, it wasn't because it was an a priori plan as an endpoint that was defined. It was out of just sheer fun and creativity and research. And so to remember that exploration is part zigzagging around and kind of looking at the flowers.
I think any podcast that ends with a Douglas Adams reference is going to be a good one. So listen, thank you so much. It has been an absolute privilege to speak to you today. It's been wonderful getting an early psychiatry perspective on the field. And it's anytime anyone asks what we bring to the field, I'm going to hold up you and your work. So thank you so much for speaking with me today.
My pleasure. And thank you.
I look forward to seeing some of the PIA's work at AAIC.
Thank you for listening. You can find profiles on today's panelists and information on how to become involved in ISTAART on our website at dementiaresearcher.nihr.ac.uk and also at als.org/ISTAART. We'll be back tomorrow with the next recording in our ISTAART PIA Relay Podcast series. Finally, please remember to like, subscribe, and leave a review of our podcast. You can do this on our website and in your podcast app. Thank you.
Brought to you by dementiaresearcher.nihr.ac.uk in association with Alzheimer's Research UK and Alzheimer's Society, supporting early career dementia researchers across the world.